All right, welcome to the next installment of Live Well with UCI Health. I'm Ryan Mano with Coast 103.5 and iHeart Radio. I am thrilled to be sitting across from Dr. Annie Wang, a board-certified general surgeon specializing in minimally invasive, gastrointestinal, and other weight loss surgeries.
Yeah, that's right.
Yes, did I get it?
Yes, I also do like abdominal wall reconstructions.
Okay.
So I do a lot of different things.
Yeah.
But that's the key to what we're talking about today.
Yeah. Is that like a good conversation starter for you? Like when you're meeting people? Like I do abdominal wall reconstructions.
I start with, I do minimally invasive surgery.
Okay.
That tends to impress a lot of people that I do a lot of things with little cuts in the skin.
That's so cool. And as we've been doing this, that's one of the, I will say before we jump into our topic today, we're going to talk about weight loss and surgeries and all that, and GLP-1s. I have been so fascinated to learn about how little we need to cut anymore.
We've made remarkable advances. And basically how we do it is we use long instruments. And it actually has even advanced the surgeries we are able to offer as a whole.
Yeah.
Like if we think about surgeries deep in the pelvis, or for my part, it's surgeries high up in the chest. It's a lot easier with little instruments because some of those places you can't even reach with a big cut.
Yeah.
And so not only is it safer than before, but also we're able to do more things.
Sure. Yeah, that's awesome. Well, let's start with this because of what you do, and you know, look, there's a lot of focus on it right now. There's a lot of talk and buzz around GLP-1s and, you know, feeling better, looking better. How should we view obesity?
Yeah, so this is actually a really interesting topic, even within our field of obesity. We've been kind of feeling around in the dark to figure out a way that helps patients the best. And so now the experts are starting to come together, reviewing all the data from all the patients we've treated over the last few decades. And some of the big conclusions that we're starting to kind of emerging concepts is obesity is a chronic, relapsing and remitting disease. So, when we see on TV, they talk about it as yo-yo diets. But what it really is a disease that's treated for a little bit and then has started coming back. And so when we view obesity as a disease, it's much easier for me as a doctor to talk about it with my patients because then the patients don't feel like, oh, we're just here for my vanity. You know, it's a disease that has consequences for all your organ systems. The ones that my patients feel first are acid reflux. They get really bad joint pain from carrying all of the weight all of the time. They also can have very high risk of heart attacks, strokes, even a lot of different cancers. And so treating obesity, I like to think of it as a surgery that sets you up for long-term success.
Right.
And so that's why we do what we do. And I kind of encourage patients to think about it from that lens so they don't kind of bring that shame piece about and worry that it's just for my vanity. It's really not.
Yeah. Is it just like on a personal level, I guess personal and professional, is it difficult for you to start to have some of those conversations with people?
It is.
Yeah.
And, I know a couple of years ago we were talking about in the media, we were looking at things like body positivity and like, so-and-so is fat shaming and things like that. And it makes us not clinicians, not just me, and this is my whole job, but primary care doctors, cardiologists. It's really hard for them to bring up that topic without damaging that patient-doctor relationship that we work so hard to build. And so sometimes we say, you know what, there's other pressing issues at this visit. Let's just put that on the back burner for now.
Right.
But the way I think about it now is it's an important conversation to have so that they can avoid that open heart surgery down the line.
Yes.
And they can avoid a cancer diagnosis, chemo, and things like that. And so for me, it's I start from a place of when you're in my office, me and my whole team of wonderful social workers and dietitians, we work very hard to foster a very positive environment.
Yeah.
So our patients feel like they can talk about anything with us. But at the same time, that means that I start the conversation. Sometimes they're not ready to hear it.
Yes.
But I at least start with a question. And then that usually opens up a lot of things that they were worried to talk about with me. And they're like, oh, it's so good that you bring that up.
Yeah.
Now I can talk about this with you and I feel safe to do so.
Yeah.
And so I think if this is something that's on a patient's mind, please bring it up with your doctor. That eliminates a lot of our fear of like that damaging our relationship with you. And it makes that conversation so easy on our end.
Yeah. So let's talk about like, the stuff that you do, bariatric surgery versus, like we were saying, GLP-1s are everywhere right now. Is it a matter of versus to you, Dr. Wang?
I don't think so. I think bottom line is obesity is a disease, but the patient is the captain of the ship, right? It's your body. You have the choice to treat it however you like. My job as the doctor at our visit is to give you all the options, right? I have a team where someone on my team prescribes these medications. And so I don't see it as an antagonistic relationship between the two. I say, what option fits the best with you at this moment in your life? And then we go through the pros and cons of all of the options, right? And so I love bariatric surgery because it's the only thing that's in the data that has the most durable long-term success.
Okay.
And so patients, we now have...
Can you pause 1 second?
Yeah.
Why? What do you mean by that? Go a little deeper on that.
Yeah. So when we talk about success with weight loss surgery, the numbers that we can compare are how long have you kept the weight off?
Okay.
And so we've been doing bariatric surgery for decades now. So we've got long-term follow-up data up to like 20 years, and patients are keeping that weight off all of that time. And conversely, the GLP-1s have been on the market for just 2 to 3 years. They do have really good signal of like dropping the weight. The weight loss is not as much as bariatric surgery, but some people really do very well with these medications. Yeah. But what we also know about these meds is when you stop taking them, the weight bounces back.
Okay, listen, I'm going to just be honest with you. We were even talking about this before we turned on the cameras. I've lost 44 pounds in the last, 15, 16 months, whatever. I notice if I don't hit my weekly dose, even a couple days later, I'm just like, it comes back. All I want to do is eat.
Yeah.
You know what I mean? And I can feel it just like that. So I'm living proof that what you just said is completely accurate.
Yeah.
And that weight does come back if you're not careful.
And so, I always say that's not kind of, it's definitely still the patient's decision to decide what route they feel the most comfortable with.
Yeah.
But like if they are ready for surgery, that's the one I encourage patients to really consider because that's one thing to do up front that then they're set for the rest of their life.
What are the different? I've heard of gastric bypass, sleeve. Yeah. What are the procedures that we're doing now that you're doing?
Yeah, those are exactly the two that are standard of care first up operations that we do. So the sleeve, it's the most commonly offered surgery in the United States. What we do is, I like to think of the stomach as like a purse.
Okay.
That's what it looks like in the operating room.
Why not?
And with the sleeve, we're cutting that purse to look like a banana. Okay. And so that's how it helps you lose weight. At any one time, your stomach can only accommodate that amount of food.
Right.
And so that is kind of the jump start to help you lose that weight. The sleeve is a great operation, and a lot of patients like it because it's a relatively shorter operation. It's about an hour for the operation, and that's why it's the most popular right now.
Yeah.
The other operation has been around the longest, and it's like what we call the tried and true operation. It's the gastric bypass surgery. This one's a little bit more complex, so you got to follow me. You take that purse.
Let's go.
We cut it down instead of to a banana, we cut it down to the size of an egg. And so it's even more restrictive. So there's a slight edge on how much weight you lose with it.
Okay.
And then that egg, we connect it to your intestine further down in the digestive tract. So now the calories that you eat, not only do you eat less of it, it's got a shorter highway to get absorbed. The rest of your stomach and that first portion of the intestine that has important digestive juices to mix with the foods that you eat, we have to help that meet the foods that you eat. So we have to make a second connection to help those.
So we're
come
rerouting
together.
everything in here. You're just, you're laying new tracks and stuff. Okay.
So
got
it is a more extensive operation. So
Yeah.
some patients are a little bit more shy.
Yeah.
But when we look at the long-term data, patients who have undergone a bypass tend to have lower heart attack and stroke rates in the long run.
Yeah.
We also find better diabetes, hypertension, and cholesterol control. But you actually achieve all of these comorbidity control really nicely with the sleeve as well.
Okay.
And so both of those are great options for patients. And sometimes for certain patients, it's not so much like which one do you like. It's more of, hey, I reviewed like everything about you, the surgeries you've had, your medical problems. I actually think this operation is the preferred one because I think these are all the benefits.
So you'll
get
make a
from it.
recommendation based on what you.
It's a very comprehensive visit
Of course,
when I first meet you.
It's not like a random thought.
Yeah.
Of course. Yeah.
And so, we take the time to really think about that. My social workers will also sit down with you and, oh man, Allison is fantastic.
Shout out, Allison. Way to go.
She knows we're doing this, so she's gonna watch this.
I love it.
But she really gets to know our patients. Like, what kind of things make them want to eat more food?
Yes.
What are the things that make them not exercise as much? Is there any sort of family or support system issues that may become a barrier to their success after surgery? And then we've got a fantastic dietitian team. There's 3 of them. And we go through with people what to expect after surgery, what's your diet going to be like after surgery, and what we expect you to maintain for the rest of your life with the surgeries. And so there's a lot of guidance. And like I follow my patients for their whole life. After the surgery, it's every few months to make sure you're losing the weight appropriately. After that, it's an annual visit, just like with your PCP, just so that we're making sure that everything's still working great.
Yeah. Okay. So when I'm on the GLP-1s, I feel like it turns the food noise off, right? Does that same thing happen to someone whose stomach is smaller, right? Like, or do they still have the desire for food and then end up stretching their stomach out again?
Yeah. So
does that make sense? Did I ask that right?
Yeah. Okay. Yeah. That's exactly the right way to ask that question. So part of it is because your stomach is smaller, you feel full very quickly.
But what about the mental? Because to me, that's always been my issue. Like if I'm bored, I just think, oh, I'll just eat something or whatever. Or I think about, it would sound good right now. But I don't, I lose that when I'm on that medication.
Yeah. And then the reason that is because those medications mimic the hormones that send that signal to your brain.
Okay.
Those hormone levels drop with bariatric surgery, and they're affected by the bariatric surgery. So to some extent, it does do that as well.
Fascinating.
And in fact, you know how they'd say like, oh, they invented these medications to treat diabetes?
Yeah.
What started them down that path was when they looked at gastric bypass patients and they said, well, why is it that these patients have incredible sugar control right out of surgery? Like literally the day after surgery, some of them don't need as many meds as they did before. And then they started digging into the hormones, and that's eventually how we got these meds.
No way.
And so, part of what a lot of us in the obesity community are thinking about is maybe GLP-1 isn't the only hormone, and how they're finding more hormones is they're studying some of these models of weight loss surgeries to really understand like what other hormones can we understand better to make drugs better.
Mm-hmm. At what point would you recommend someone really give some real serious thought to consideration to gastric bypass surgery?
So not just gastric bypass, but even the sleeve surgery. The guidelines right now recommend that if your body mass index is above 35 or it's above 30 and you have comorbidities of obesity, that you should see us. Well, that's very hard for a patient to understand. So what I recommend is that you get your height and your weight. Okay. The day that you're thinking about this question, you stand on a scale and you get your weight. And then you can look for BMI calculators online and calculate your body mass index.
It's that simple. You need your height and weight. I've never done this.
Yeah. They're all over the internet. I think ChatGPT can do this too. Yeah. It can do a lot of things, but it can't do the operation.
No. Yeah.
And if that number is 35, make an appointment. Maybe it's with me. Maybe it's with your primary care doctor. with one of us and say, I think I need to think about how to tackle this problem of obesity. And then we work with you to figure out what are the options that may work the best in your life.
Yeah. You mentioned something about, staying with your patients, following up with them for, forever, basically. What does that look like? Like the full after surgery thing? When you say follow up with them, like what does life look like for you as their surgeon and for them and together?
Yeah. So based on how we describe some of these operations, it's actually very easy to think that the way that we eat is changing.
Okay.
And so it's very, and we're doing a lot to manipulate the GI tract. And so there are certain vitamin deficiencies and that are more common in patients who have had surgery compared to the general population. And so I monitor for those. But as long as we're sticking to the diet plan leading up to surgery, that should be okay. But we check in on that. We check in on what your weight is. Because again, obesity is a chronic disease. Weight recurrence may still happen, though it is much lower percentage than with the medications. And so we kind of stay on top of it and see like if things are starting to not look great, we're right there for you.
Okay.
But
do you know, like, can you... Maybe you don't want to answer this, and that's fine if you want to plead the fifth. Do you know when someone's not sticking to the plan and they're trying to tell you, no, I've been doing it, and you're like, come on, you haven't.
There are certain tells.
Yeah, I bet.
Yeah. So what I do is I have my patients lose some weight on a trial run of the diet before the surgery.
Okay.
And if you don't lose weight, that is one of the signals to me that you may not be ready for the surgery. And we work a little bit harder. And it's not because, I really need you to lose weight, like my surgery is going to do some of that work. But I also know that patients who can't really realistically stick to the plan in a long-term fashion, they're not going to be that successful after surgery. And I don't want to set my patients up for something like that.
No.
And then the other part of it is the preoperative weight loss actually shrinks the liver away and makes the surgery easier and lower risk of complications on my end. And those are kind of the biggest reasons why I kind of have them do that even leading up to the surgery. And there's not really a point in lying to me or your doctors about this stuff because you're the one living the life. And if things are not working out, we do food journals, and you can look at your own food journal and kind of be reflective about it and see your own progress. And once you have identified, actually, you know what? Always like at midnight, I start having these cravings. Let's talk about that.
Sure.
Then we have a lot of options, right? Yeah. But as long as we keep the lines of communication open, we've got a lot of different strategies to help you. But of course, everyone's got to come to the table with honesty.
You touched on a couple of these in one of your answers. What are the key benefits to having a procedure like this? You talked about comorbidities, like decreasing, right?
Yeah. So a lot of patients who have really hard time controlling their diabetes and their sugar control. Every time they talk to their primary care, they're like already on insulin. They don't feel that great. Sometimes these surgeries can kind of help with the insulin resistance a little bit.
Okay.
Though at that point, it's a little bit too late. The best time to help with a lot of these comorbidities is before they even happen. That being said, we do see reduced rates of cancer and reduced rates of heart attacks and strokes.
Of course.
The things that my patients feel immediately, other than needing to take less medications for the blood pressure and the diabetes, is they can live a life now.
Yes.
A lot of my patients, one of the biggest things that actually makes my patients come see me, and it's really great, is my wife's about to have a baby and I'm scared I can't keep up when they're on the football team or something like that.
Yeah.
And a lot of my patients, like even 3 to 6 months out from surgery, they're telling me they're running 5Ks. They are keeping up with their kids. They are so relieved that their body can function again. And that to me is the most important part of this surgery, is that you can live your life again.
That's awesome. Yeah.
And then like back to the body positivity thing, to me, I don't really care what my patients look like. Like if you are larger or smaller, what matters to me is that you can use your body and you can function. You can do the things you want to do. You can swim, do the water aerobics, or, run on a field again. Like all of these things, that's what matters to me the most. And so I don't really worry too much about body positivity. The most important is I get my life back.
Yeah, 100%. And look, and maybe this is vain. I don't know. There's something to it. And I'll use myself as an example. Like, you feel better when you look better, and you feel better when you fit into your clothes better. And when it's really, that's a huge benefit. I know it's not like something you can treat as a doctor. It's not like, you're going to look better in clothes. That doesn't matter. It's about health, obviously, for you. But there is something to be said for waking up and feeling better about how you look or how you feel in your own skin.
Yeah. And the reality of the matter is, unfortunately, obesity is a very visible disease. And so it's very common, actually, for me to hear from my patients, they've been bullied their whole life because of the way they look. They get treated differently walking out in the real world. And then one of the things that actually a lot of patients work hard to cope with is it's really hard to deal with the fact that the world treats me different now that I look different. And that's another reason why we are so diligent about finding, really understanding the things that have plagued our patients for a long time, so that these are things that we can watch out for. Like, hey, just so you know, these are things that we know may be triggering for our patients after surgery.
Interesting.
And kind of keep your eye out for stuff.
That's cool that you do that. So those are the benefits. Let's talk about the risks, potential risks.
Yeah, there's a risk with surgery always. Every time we cut the bowel or the stomach, there's a risk of leakage.
Sure.
Patients with obesity are at higher risk of things like blood clots to the lungs or the legs with surgery. And there's also risk of things like ulcers in the stomach, as well as we talked about the vitamin deficiencies. And so we do a lot of things to kind of minimize these risks around the time of surgery. We do very intense diet changes to minimize the pressure around where we've sewn things together. We also counsel our patients about things to look out for, to call us. Any abdominal pain after these surgeries, not really anticipated. You need to be calling us.
Yeah.
And just having a very well-oiled machine with our whole team. We all know what to look out for, so that if the patient reaches out to any of us with these issues, we're on it, And what I tell all my patients is I can't prevent complications, but what I can promise is that our whole team is there for you if anything happens. And we've dealt with a lot of it. UCI is the tertiary referral center for the Orange County area, actually the whole Inland Empire. And so we've seen it all. So we can definitely deal with whatever happens.
What is the recovery process like, typically, on average? So, how long are we laid up or in the hospital? What's that look like after?
So with the sleeve, the banana surgery,
that's
what we're going to call it now.
Right. The old purse that's now a banana.
Yeah. So with that surgery, you stay in the hospital for one overnight and you're home.
That's it.
And then we follow up with you in 1 to 2 weeks after surgery.
Yeah.
We usually ask patients to take about a month off work so they could really focus on the diet. But most people don't really have a lot of pain beyond that first week after surgery.
No way. Wow.
Yeah.
Is the diet so let's say you're home after this, is the diet immediately different, even like a liquid diet for a week? Yeah.
So even before surgery, we do 2 weeks of a liquid diet, and that's helping that liver shrink like we were talking about. And then that continues for that first 2 weeks after surgery. And then the next 2 weeks, we do a pureed diet. And then it's a soft diet. And then we slowly go back to regular food. Because the stomach is smaller, you have to eat smaller meals about 6 times a day instead of 3 square meals.
Right.
And then we also very, very strongly tell patients to stick to a high protein, high fiber diet. The proteins help you heal from the surgery. And the fiber and the proteins help you feel full for longer, so you're not craving a lot more foods. Carbohydrates, especially after these surgeries, can make patients not feel as well anymore. And so we try to stick to a low-carb diet after the surgery as well.
So that's the banana.
Yeah.
What about the egg?
So the only difference with the egg is you stay one more overnight on average
2 nights
at the hospital.
2 nights versus 1.
Yeah. And then everything else actually largely feels about the same.
Yeah.
And then with both surgeries, we want to try to prevent ulcers. So we tell patients, you got to quit smoking and alcohol and even marijuana products for 6 months before surgery. And then going into the surgery, you can never have those things again. And then if you like to take things like ibuprofen, Motrin, naproxen, you got to think about stopping that and switching to maybe a Tylenol or something else to control the pain. Also knowing that a lot of your pain is going to go away with the weight loss as well. And so we just got to find something that works so that you don't threaten your surgery while you're just trying to feel better.
That's really important to know. I didn't know that you can't go back to those. Like if someone, like to have a nightly drink, they're not doing that.
Yeah, it's hard.
Yeah.
And we kind of talk about the stresses that happen after weight loss. And a lot of times, because food has been a source of comfort for a lot of our patients, when that's taken away with the surgery, sometimes people turn back to their old vices, and then like things just snowball out of control.
For sure.
And so we stick to a very, very tight no drugs and alcohol situation.
Okay.
Yeah.
Does obesity affect fertility?
Yes.
It does.
Yeah. And so a lot of times my patients will tell me, like, I've been trying to conceive with my partner and it's just not happening. Or the other thing that actually I hear about even more commonly is women who come see me and they're like, I have obesity, let's treat it. And then I ask them, oh, by the way, do you have really heavy periods? And across the board, they'll either say, I have really, really heavy periods, or I don't have periods anymore. And it's because when you have an accumulation of fat in the body, one of the places the fat likes to go to is your pituitary gland in your brain. And that's where a lot of your reproductive hormones are made, and it gets all out of whack with obesity. And so treating the obesity, we do know from early studies that are emerging that that regulates your menses after surgery. And there's some signal in the data that's starting to emerge that a lot of patients can have successful pregnancies after surgery. That being said, we do not want patients to get pregnant within that first year after bariatric surgery, just because that's the year where you're going to make the most progress on your weight loss.
Oh.
And so it does pose a certain risk to the infant as well as the mom.
Yeah.
And so we are very strict about that as well. And so if that's something you're interested in, you can still see me and we can make a plan. Like, let's say, actually, I understand that. Let's treat that fertility piece first. Let's get you plugged in with someone that we know who can help you with that. And then when you have that baby, come back and see me.
Wow.
Or, hey, you know what? You're young. You got time ahead of you. Let's do this piece first.
Sure.
So that you can kind of have a safer pregnancy a year out from now.
Yeah.
Right.
Yeah.
And so a lot of that is very tailored and personalized to the patient that's sitting across from me in the exam room. And we make that plan together.
Okay. So you mentioned that UCI Health, and what word did you use? Tertiary, I think.
Tertiary referral center.
That's the word. I flagged that. What sets you guys apart?
So because we are an academic university hospital, we take on the responsibility in our region of treating patients where the community or the private hospitals just say, this is too complex of a case. This patient maybe suffered some complications from another operation. They need a third set of eyes on this. And then that's when they turn to us. And so that's one of the biggest benefits of our center is we see a lot of complex cases. And so that means that, whatever happens, we've got something to figure out.
Yeah.
Yeah, we've got a team to figure it out.
Of course. Is there anything else that you want people to know? Like, if you were to just say, this is my message for someone who may be watching this, hearing this, who is really struggling and they don't know what to do. What are your words to this person? Reach them.
It's never too late.
Good.
And don't let the anxiety of acknowledging that there's a problem get in the way of us solving that problem. And so if obesity is something that's really impacting your life and it's something that you think about, plug your numbers into that BMI calculator and make an appointment to see me.
Good.
And we can figure it out.
Okay. You're wonderful. Honest, and I'm not kidding. I feel like you should host a TV show for like kids and explain this, because the way you put the banana and I followed everything you said in a very, like, I don't know.
In my office, I have pictures.
You do?
It's even easier to follow.
I love that. You make everything so like understandable, and that's a skill in and of itself. So thank you.
No, thank you for having me. This is super fun.
It is. I'm Ryan Mano. That's Dr. Wang. Live well with UCI Health. Thanks for watching and listening.